Good morning, everyone, and welcome to the Heart Failure Quality Exchange Call. My name is Michelle, and I will be your moderator for today. Feel free to ask questions throughout the presentation by typing them into the Q&A box on the right-hand side of your screen, or dialing *6 to unmute your line. If you would like to zoom into any part of the slide, use the magnifying icon located on the left side of the slide. The slides and the link to the recording will be provided within 1 week of this call. I would now like to turn the presentation over to our Regional Vice President of Quality for the Southwest Affiliate, Cherie Boxberger. Cherie, the floor is yours.
Hey, good morning, everyone. Thank you for joining us for our quarterly quality exchange. And I do want to emphasize what Michelle just said, and that is we're really here to be able to answer your questions. I'm going to present some information based on the data that I've seen and kind of what's going on in heart failure. But this is the forum where we'd love to hear from you in person. If you're willing to do that, you just *6 and you can come off mute, and we'll be offering that several times during the program. But you can also type in those questions, and Michelle will kindly read them off and so that you can get your answers based on Get With the Guidelines heart failure. So first of all, just want to continue to thank you for your work in meeting the needs of our heart failure patients. I know I'm preaching to the choir when I say this is such an important area that because of all the fine work we've done in STEMI care and stroke care and saving patients, we will, over the next few years, have more and more heart failure patients. But I'm so excited and it's a privilege to know that you are the individuals who are helping us provide that care. So a couple of weeks ago, these are what we're going to talk about today. You should see the slide. We're going to talk about our day-to-days. 2 weeks ago, you should have received an up-to-date report. Well, not up-to-date, a snapshot report as of January 1st, and we'll talk a little more about that. Out of that, I want to talk about 3 measures, and if there's questions you have about other measures, don't worry. We're going to talk a little more about ARNI. There was a study that was a late breaker that was given at the November scientific sessions in Chicago. That's since we last spoke, so I want to be able to share that science with you if you haven't seen it. I want to talk about post-discharge appointment. We have some big news and some clarification that's going to help many of you. Talk about pneumonia vaccine, because I see we're having a little bit of confusion as it relates to what the CDC guidelines are. An upcoming program that we're going to have, a national program, and then I'll give you some key dates. So that's what we're working on today. As we get going, and I'll forward my slide ahead because I think we will, of course, always be seeing this slide, and this is called evidence-based therapies. You'll also see this called guideline-directed medical therapies. And the fact is that these therapies, and there are more that you keep track of, but these therapies, and you can see it right here on the chart, they reduce relative risk, they have relative risk reduction in mortality, and they also impact readmission. And there is excellent science behind this. And so, of course, that is why Get With the Guidelines exists, is to make sure that our patients get the guideline-directed, the science-based, evidence-based therapies that they should have. So I will share this every quarter. It's important for hospitals to measure this, no matter whether they use our tools or not. We just feel like Get With the Guidelines heart failure is the best way to keep track of those evidence-based therapies. Something I wanted to mention related to day-to-days, which, and I'm sorry, you were told how to make this bigger, so I apologize. And these are going to be aggregate results for the 6-state Southwest affiliate. And as a reminder, the area that I work with that's included in this is Arkansas, Colorado, Oklahoma, New Mexico, Texas, and Wyoming. And that is the Southwest affiliate. So when you're seeing this aggregate data, it is for all of the Get With the Guidelines heart failure hospitals in those 6 states. Before we hop into this data, there are 4 new directors of quality in the Southwest affiliate, and you should have received your day-to-days report from your new quality improvement director. And I'll just mention those if you've missed that or if that email somehow was lost. Serving North Texas, and that's going to be the Metroplex as well as a little bit up north of Dallas, is Christy Esposito. And so she is going to be working with all the customers in that area. Alicia Webster has joined us as a Director of Quality for all of Oklahoma, as well as the kind of what I'd call the northern rural Texas. So everything side to side from Lubbock and Amarillo over on the west, across the top of the state, Abilene, Paris, and then all the way over, including Tyler, Nacogdoches, at Longview, that area. So Alicia Webster. We have divided up Colorado. Colorado now has 2 Directors of Quality. Emily Jones joined us in October, and she's doing northern Colorado, so that's going to include Denver. Northward, they've divided that up by regional trauma regions. So, and then she's also doing Wyoming. And then those of you, Colorado Springs and South, are going to be served by Flannery O'Neill, and she's also working with New Mexico and the El Paso area. So very excited to have this new group of quality improvement directors on. If you haven't met them and you're not sure how to reach them, you can always email us at SWA, and that stands for Southwest Affiliate or Southwest Airlines, but SWAquality@heart.org. So let's hop in here. Once a quarter, your director, who's assigned to your hospital, will run your reports for you. She is going to, they happen to be all women right now, so I'm going to say she. We've had gentlemen as well, but she will run all of your results up to that point. It is a snapshot. We have to pull that data at one point, and this particular data for most of it was pulled on January 1st. So we're able to look at the 4 achievement measures. And the reason we're doing this quarterly, sometimes I know you probably know how to run these reports. If you don't, get with your director. But we want to just take that burden off your plate. Sometimes you're abstracting this information and you just don't have time to run the report. So you should have received your year-end first report. And, of course, since it was pulled on January 1st, we're aware you weren't done with your abstraction for 2018. This is the performance as you look Q1 through an aggregate. So what you're seeing there, for instance, ACE, ARB, ARNI, is Q1 in blue, 2 in orange, and these may show different on your computer. 94% is Q3, the 92% is Q4, with an aggregate for the whole year through January 1st of 89%. So as we look across our affiliates, we're seeing excellent performance as it relates to the ACE, ARB, or ARNI. We're going to talk a little more about that ARNI piece, but we are doing well. My guess is when we finish that, we're probably going to go up a little bit when we have our year-end results, but doing really well. Again, a guideline-directed therapy, let's just remember and go back to our chart. When we talk about ACE-ARB, and this was done separate here, but when we talk about ACE-ARB, you're talking about a 31% relative risk reduction in hospitalization and a 17% risk in mortality. So that is why we want these patients to have that treatment. All righty, evidence-based beta blockers. This used to be difficult. We had a lot of docs who were using something other than the 3 specific beta blockers, but we're seeing great improvement in that area. I think the measure LV function is becoming a regular part of your process.
I think we might have lost Sherry. We're going to give her a couple more seconds to join us back on. But I will take this time to remind everyone that for our 2018 awards, abstraction must be completed by February 28th. So you have just received your report. You're seeing how you're doing so far throughout the year. Just make sure to plug in all your data by February 28th. This will give enough time for your directors to re-review it, see if they could catch any errors before we go to print and before awards are announced. If you have any issues with running your report, or if you are having problems in one specific measure, reach out to your director. They're more than welcome to guide you through some best practices to try to improve that measure.
I'm sorry. There's a little gremlin on my phone that wants to disconnect me. You can hear me okay, Michelle?
Yes. Welcome back, Sheree.
Great. So sorry. So LV function, great. Post-discharge appointment, we have been improving in this area, but I have a very important clarification, which is going to allow you to make some edits on your 2018 data and be able to, I think we're going to see a big improvement here because we went back to our national committee and their intention was in that. And so we're going to be having a change in the coding instructions. Those haven't happened, so I'm going to give you some guidance on that. All right, let's jump ahead then. These are the achievement measures. So this is how you get gold, silver, silver for 1 year compliance, gold for 2 years of compliance. You have to have at least 85% in all 4 of these to even move to the next section. The next section we call the plus measures. And so when you look at these, you do have to be at 75% in 4 of these. So when we look at those, you've got your aldosterone antagonist. Again, don't forget our chart. I think because this is a measure that is in the plus, sometimes it's forgotten, but I think if you visit with your cardiologist, this is an old treatment, a proven treatment, and has fewer side effects than any of the others. And look here on our evidence-based therapy chart, 30% reduction in mortality, 35% reduction in hospitalizations. So we really need talk with your champion about this because this is an important one, and I'm seeing we're improving, but I am still seeing low performance as it relates to this Class 1 recommendation. So it would be a great thing for your heart failure committee to work on. We're going to come back and talk about ARNI. That, of course, lots more information has come out about that. Other ones that stand out, we're going to talk about both the post-discharge appointment and the one on the bottom there, follow-up in less than 7 days. Look at that fantastic improvement over the year by the Southwest affiliate where you are able to get those appointments in. That is not easy. You can't do it sitting at your desk. You have to be convincing these physicians to take these patients in a timely fashion or providing other mechanisms, heart failure clinics, et cetera, to be able to see these patients. It's very difficult. And I mean, I couldn't be more proud of you for seeing how that's improved. We're not going to talk about it today, but don't forget hydralazine nitrate is a Class 1 recommendation for those in the Black community. And so heart failure patients, it's the only particular specific guideline to a particular race, but it's important to look and has very good science behind it. And then we're going to talk a little more about pneumonia vaccines. I've had a lot of calls about that. And then, of course, heart failure, heart failure honor roll is when you're able to achieve on all of these. And the added measure there is referral to a heart failure disease management program. And when you look in your coding instructions, that has a broad definition. It can be cardiac rehab, it can be a heart failure clinic, but it isn't just a single appointment, it's an actual program. And if you want to know more about that, speak with your director. Any questions at this point in the Q&A, Michelle?
None so far, but I think they're just taking in all the knowledge.
Or they're all just getting their second cup of coffee. That's fine. That's what I'm doing also. Well, let's talk about ARNI a little bit. You remember that in 2016, there was an emphasis on this through the study that was called Paradigm HF. And when we looked at Paradigm HF, and I've got they found great outcomes. In fact, the study was stopped because they could not, in good conscience, continue the other arm of the study because it was clear they were not getting the best care. So actually, the study had to be stopped. And then we just had a more recent study called Pioneer HF that I want to show you the information on that. So right now, our performance on this as an affiliate is 12%. And interestingly, the performance, this is the whole country, the performance in the country for Q4 is 21.2%. So I feel like we're a little bit behind, that this is going to be something you're going to want to share with your champion. And if you And we can certainly send you the documents to be able to look at that a little more closely, and if necessary, connect you with a physician to talk it through. So let's talk about what the science is. Go ahead.
I just want to interrupt you with one question regarding a previous statement you made. You said heart failure clinics have to be a program, not just a follow-up visit with the cardiologist?
Now, we're talking about two things, and so here's your plus measures, and you notice on here we see follow-up within 7 days. On target heart failure, target heart failure, where did my slide go? Oh, here it is. Then we've added this one to the far right, which is called Referral to Heart Failure Disease Management. And in there, there's a very specific definition. Well, it's not specific, but it's a broad definition that talks about the 60 minutes of education. It talks about cardiac rehab being an option. It talks about referring them to an actual program. So please, that's a completely different measure than the post-discharge appointment and a follow-up within 7 days. Heart failure disease management is another element. And so if you have questions, go to that part of the coding instructions, because there's like 4 things that meet the criteria, and you have to refer them to one of those. And we can follow up on that and do more education if it looks like. Is there a follow-up question in there, Michelle?
No, I think you answered it. Thank you, Sherry.
But remember, 3 different things. Post-discharge appointment. Was there a date, time, and location in the medical record? That's that measure. Measure 2, did they get a follow-up visit within 7 days? Did the patient actually get in there in 7 days? Not that their appointment was made within 7 days, but they actually had an appointment in 7 days. And the third one, they were referred to heart failure disease management. 3, not distinct, but 3 related but separate measures. Good question. So here we are on our ARNI. So as I mentioned, we're about 12%, and you can see that nationally around 21.2%. So let's hop into, I want to share with you the science that was shared this was actually a late breaker, they call it, where it was one of the pieces of data that was in a bigger setting where the data had just come out. And just to give you a little background, the original study, Paradigm HF, it included acute decompensated heart failure. Well, no, that's not true. Sorry. This is just giving you the background. A lot of people have decompensated, and there's 25% are readmitted. But what they did in Paradigm is they took stable, very stable patients on heart failure. They actually excluded any of the acute decompensated heart failure patients. So they had this certain group of patients that they were studying. So that was Paradigm HF. And in that study, it very clearly, and you can look there, the p-value that's 0.001, as we all remember from our dreaded statistics classes, that is statistically significant. So when you look at cardiovascular death or heart failure hospitalization, when you look at the use of ARNI at a 21.8 compared to enalapril at 26.5, it definitely, it reduced death and hospitalization. You can look at some of the other elements. They're also lower, but they were not statistically significant. And then look at death from cardiovascular causes. Again, not statistically significant, but definitely lower. So anyway, it was stopped. Paradigm HF was stopped. That's when ARNI was added to the guideline a couple of years ago, because it became clear that ARNI was a treatment that we should consider. So we did ACE, ARB, and ARNI. That was the recommendation that came out in our guidelines. So part of that is that they realized that when you were looking at this particular measure, NT-proBNP, and what the likelihood of cardiovascular events is that if your treatment could manage that measure, if it could manage, if it could keep NT-proBNP less than 1,000, then there were less deaths. So that was basically what the medication was doing. So they put together Pioneer HF. Now they're taking those decompensated heart failure patients, and these are all reduced ejection fraction patients. These aren't preserved. They took that decompensated group and they put them in a new study because now they could see it helped with this other group, these less sick heart failure patients. Will it help with these patients? And so this was, they had been hospitalized because of decompensated heart failure. They had, at some point, they had less than, their EF was less than 40 in the last 6 months. Their NT-proBNP was greater than 1,600, or their BNP greater than 400, and they were stabilized while in the hospital. So they weren't unstable in the hospitalized situation, but they definitely were decompensated, and these were not included in the original study. So, and this kind of tells you what their doses were and so forth, and I'll send this out if your physicians would. I can send you the whole study if your physicians would like to look at it. What they were looking at is whether they could get a change in that NT-proBNP in 4 to 8 weeks. And they were watching for worsening renal function. They were working for hyperkalemia, because that's the number one reason people don't get ARNI other than cost, is hyperkalemia. They're looking for hypotension as well as angioedema. So, and the patients were similar. This is just proving that the two groups were pretty matching. And what they were able to look at is that it was really significant. They were able to drive these patients, their NT-proBNP down and maintain it. And they didn't have worsening renal function. They didn't have an increase, at least a statistically significant increase in hyperkalemia. Anyway, it was safe to do so. And then these are the results. So death reduced, rehospitalization reduced, as well as if they needed to have an LVAD. And what they did is they had a composite, and it did have a p-value difference. So when you look at that index they used, the serious composite, where they kind of combine those, then it was statistically significant. All right. Just making sure I'm still connected. Sorry. Afraid I'm just talking to myself. Any questions? So you can see, you can see that it's an important element for us to get our patients on these. Now, it requires them being off of ACE for a period. These patients that were put into this were on a 36-hour wash where they didn't have any of their, you can have some significant problems when you have been on an ACE and how you make a transition. Certainly, expense continues to be an issue, and it requires special approval. What are other roadblocks, if you don't mind, to having your patients on ARNIs? If you can type those in or come off in *6.
While people are gathering their thoughts, Cherie, can you go ahead and explain a p-value one more time?
Yeah, I want to make sure when somebody says something that is statistically significant, then, and let's just look back at that other one because it shows, because sometimes things will be less, but they're not statistically less. So it says you're more likely to go in the hospital, to be hospitalized if you're not on this drug, and they'll look at a measurement. So example on here, hospitalization at the first event was 12.8, and with an enalapril it was 15.6. If you look at that individually, it is not statistically significant. If you took that and added more patients in or less patients in, you can't say that statistically it's going to happen again. It's less, but it's not statistically less. So we're always looking for a p-value of 0.001, 0.002. You're always watching those to make sure it's something that's not just less, it's statistically significantly less. And I took 3 graduate level statistics classes, and my teachers would just be rolling over right now. But you just want to look for it to be in that area to know it applies.
Thank you, Cherie. We also have a comment from Jackie. She says the primary lack of ARNIs being prescribed is cost prohibited here within her community. Any help coming from drug companies on this?
Yeah, you know, we've done 16 heart failure breakfasts across our affiliate. We did 13, and then we've had some second and third ones. And this is a significant issue. In the institutions that are doing this well, the drug company seems to be really working well, but it's requiring them to have a dedicated person dealing with these high-cost drugs. So we're going to keep an eye on that. Certainly, we've brought in our advocacy partners, but, you know, we don't have an answer right now, and so there is no question. We also have to get it added to formularies because a lot of things are not added to the formulary, and so then they aren't prescribed within a given institution. And so that's probably the first step, is to make sure they're on the necessary formularies. Then once they are, to look at the people who are excluded financially at that point. And even if you get the first one funded or the first prescription funded, I mean, there has to be the concern, can these patients stay on the medication? And so we have our finger on the pulse. Unfortunately, we're just measuring the pulse right now. We haven't impacted it. So that's what we're hearing, Jackie, and we need to keep watching that. Other comments, Michelle?
That's the only one so far.
Okay. Well, I'm going to hop ahead. I would like to talk more about ARNI and roadblocks, and especially if there are roadblocks related to physician education, or we could help on that. Let's talk about the post-discharge appointment, the bugaboo forever, because you know for 4 or 5 years we allowed hospitals to do discharge instructions instead of post-discharge appointment in the record. And then a couple of years ago, we said no more alternative measure. You need to be doing this because it really leads to a good transition. So you can see this is all hospitals, all in Get With the Guidelines Heart Failure, how we've done well over the years. And you can see here, even in the Southwest affiliate, we're just going up. But we haven't been able to break that. Many of you have not been able to be recognized because you just can't get that 85% measure. So we went back, not me, our National Center consultants, they went back to our committee, our national committee. It includes Dr. Greg Fonarow, Dr. Clyde Yancey, a number of national known physicians, and asked them as it related to the intent of that. And so certainly this appointment is the first step in a smooth transition. It definitely needs to be. We're trying to set up an appointment with a physician, an APM and our PA. And we're doing this for patients that are staying in our area. Patients, of course, can always refuse. That's a reason to get them out of the measure. But here's the change. The National Clinical Work Group, and this is not in your coding instructions, so that we're kind of preempting that because of the award season, they provided a clarification. Ideally, all patients will have a post-discharge appointment, date, time, and location in the medical record at the time of discharge. That is our goal, is to have that. And that should be the case whenever it's possible. But the key word there, according to the committee, and I have the email from Dr. Fonarow, is that it was in the medical record, not at the time of discharge. So we realize, and I've talked to many of you, that you're using other mechanisms to guarantee the patient will be seen within 7 days. I know that one of our Colorado partners has actually contracted with a company that will call all patients the next business day and make their appointment. In our old clarification, those patients would fall out of the measure because that call is happening post-discharge, even though it's the next business day. We have other folks who have a designated department, a customer service department, if you will, a nurse call line, that is having those patients getting those appointments made. Again, they don't work on the weekend, but they will do the very next business day. That is now allowed. So as you look back, well, going forward for 19, if there's an appointment date and time and location of a follow-up appointment in the medical record, even if it was made the next business day, then you can answer yes to post-discharge appointment. Going backward, because some of you need to be able to correct this so you can be recognized with this new clarification, you can edit your 18 data to add the appointment date and location. And your director can assist you in running a report that will include these patients. Now, I want to be clear, and I don't know how they'll write this in the coding instructions. They were very clear that they didn't want this to be where nobody was getting their appointments before discharge. This is just the reality that there are some patients we cannot get, or we've set up official programs that are taking care of it 100% of the time, but they're doing it on the next business day. What questions do you have? And these may be hard to type out, so feel free to do *6.
Hi, Shireen. So Laura has a question. Is there a certain time frame for the post-discharge appointment to count?
In terms of when it was made? There's two things here. The post-discharge appointment, we're talking about when was the appointment made, okay? So we're not talking, maybe you made the appointment immediately and you couldn't do it, the actual appointment is not for 14 days. In that instance, the answer would be yes, you've met the post-discharge appointment requirement, but you will miss the 7-day appointment requirement. So this is so complicated here. So we definitely, because we're wanting to get them in 7 days, and that 7 days is not, I don't think is business days. So we're wanting to get them in 7 days. So this is going to have to happen quick enough to make the patient get in 7 days. You can't, in 2 weeks, call all your discharges and get them all appointments, and those count. So if you have specific ways, I'm using next business day right now. I'm not sure how they're going to put it in they may put some specific guidelines in the new coding instructions, but that's what I'm using, is that it's getting accomplished the next business day. Oh, I can see the questions. I didn't know I could see the questions. Let's see, Amy.
I'm the one that typed that question.
Okay, go ahead, Laura. Yep.
Hey, so, because I know, there's the 7-day follow-up, and then there's just what we're talking about now, the post-discharge appointment. So, like, for example, if we're going back and looking at 2018, what's the time frame for the appointment to count? Like, if they were discharged and then had an appointment 3 weeks after discharge, is that counting for the generic post-discharge appointment?
Was it when was it made? When was the appointment made in relationship to their discharge?
So for
not the date of the appointment, when did the actual person call the doctor and say, can you get them in?
So for a lot of these, like for going back to 2018 to review, we don't have the date it was called. I'm using like outside, like Epic to see when they went to their cardiologist. And I didn't know, and some of them are going within a week, and some of them are maybe like 3 weeks after they were discharged. And so I didn't know when we're looking back at 2018 what's going to count.
Well, we'll work with you individually on it. What I would start with is running a report of the patients who did not have yes on post-discharge appointment but were seen in 7 days. So we would run those first. Realize in all of these, the requirement's 85%. So that's what I would start with, because clearly it was made very quickly if they got in the 7 days. So I would filter by everybody who's, if you have a mechanism to look at those appointments and run discharge date and appointment date, if you could just get that list, then we'll look in the PMT and work through those.
And then if
does your outside person provide that where we could compare a discharge date and a appointment date?
We have, I'm going back and getting the appointment dates. So we have a list of all of the missed appointments. What I'm wondering is if we go back and see that they were greater than 7 days from discharge, are those counting, or is it only the 7 days?
Well, we need to have we don't have, it doesn't sound like you have documentation of when those were made. So I probably would start with that other group, the 7 days and under, and edit those first, because we know those were made quite quickly. Otherwise, they wouldn't have been seen in 7 days. And then on an individual basis, we'll look and see, and we can look and see how many that is and how it impacts. This change in the middle of a recognition season, makes it hard, but we're going to work with you. We're not trying to cheat the system. We're just trying to get you the recognition you're due. So let's look at those individually, Laura.
Okay. So broadly going forward, the appointment, the post-discharge appointment, not the 7-day one, but that first category, just post-discharge appointment, is still needs to be within 7 days. There's just flexibility on when the appointment's made?
Yeah, 2 different measures. When was it made? It has to be made before discharge or the next business day. So if the patient got out on Friday, somebody on Monday is getting them an appointment and it is made and they're working on it. So that's a post-discharge appointment. Different measure. Was that appointment made was it held in 7 days or less?
If we make an appointment before they're discharged and it's 3 weeks from discharge and it's in the record before they're discharged, does that count?
It counts yes for the post-discharge appointment, no for the 7-day follow-up.
Is there a time frame?
It's 21 days.
Doesn't count, like it's too far out?
Well, that's where, I mean, the goal is really next business day. You know, I'll see what they put in the coding instructions. For going forward, I believe it really needs to be the next business day that it's handled.
Oh, no, sorry. I mean, like the appointment's made before discharge, but let's say for whatever reason it's not for 6 weeks from discharge.
I mean, it's going to fall out of the 7-day measurement because it's too far out, for sure. For the
first one, I guess I'm just wondering if there's a time frame to take that appointment's too far out.
Someone providing clarification there for me from my team?
I am, Sheree. I'm trying. I'm sorry to interrupt, but I think I know what we're trying to say.
Good. Yes, go.
Forget about the quality measure. Just talking about the achievement measure. Forget about the 7 days.
Yes.
Forget about so if the appointment is made before discharge just for the achievement measure, so is it still falling, and you're just looking at the yes or no, did it happen or not? Are we still beholden to that 7 days, or?
No, it's unrelated.
Later,
it's unrelated.
3 weeks later, how far out? So 3 weeks.
They're unrelated. Early. These measures are unrelated. You've got your post-discharge appointment was made. So see here, I've got it up here. The post-discharge appointment was made.
So we know that. So that said, what is the time frame that the appointment would have to?
It doesn't. It's not in there. I mean, it could be next year. Specified. That would be terrible.
Right.
But it's unspecified.
Okay.
Thank you.
They're assuming. They're assuming. Thank you, Sarah and Laura. If I was missing I depend on our team. Let me tell you.
Between the two,
this is very confusing.
I know.
It only takes 7 of us to answer, and we're willing to use all 7 of us to answer. Yes, completely different measures. But I know that other people on the phone are struggling with this, so I'm so thankful that you've asked it that way. So this post-discharge appointment is, did the appointment get in the record?
Okay.
The other measure is, when did it happen?
Okay, perfect.
And so that's how they're separate.
Okay.
Other questions? Let's see. Amy answered a question for 2018. Yes. We have some folks who are working either with their third party or they've asked their PCP list to give them the date. That is fine for 2018. If you want to go back to those folks and make those calls to PCPs or have them give you a list of when their appointments were, you can do that. Good question, Amy. Am I missing any others? Okay. Michelle, can you still hear me?
Yes, I can.
Okay, just checking. All right, so there's going to be a lot of questions, and talk to your director. We are happy to help you. And we'll just look through, and we'll run reports. Oh, I put that on there. They'll help you run a report out of a PMT so that you can make your editing as efficient as possible. All right, let's see. Oh, I wanted to real quick talk about the pneumonia vaccine. I'm hearing some variations. There seems to be some confusion as it relates to patients in the 19 to 64 age group. Of course, the patients over 65, they should have the pneumonia vaccine. But according to the CDC, and I actually copied it in here, patients from 19 to 64 should have the pneumonia vaccine if they have heart failure. And this is actually copied from the CDC website, chronic heart disease, and that includes everything except hypertension. So you may want to look back at your how your algorithms are working on immunizations at your hospital and see if you've got these folks in line, if it's popping up that they need to have the pneumonia vaccine. And I refer you, there is a 2018 update to the CDC vaccination guidelines. And so it's possible there was an earlier version. So I'm seeing a lot of you who are asking about the under 65 group and the pneumonia vaccine. Any questions about that I'm making it worse, not better? Any other questions in general, on things you're struggling with abstraction-wise? Think about it, type them in. Want you to have some important dates. The important dates are that March 1st, just a second, I gotta change headset. Okay, March 1st, that is the absolute, we would like you to have all of your Q4 data in there. If you have it done now, we're glad to work with and make sure you're eligible for recognition right now. What happens is that though the final due date is not till the end of March, if you don't finish your data until the end of March, we have no way to work with you to look and see if there's some fallout, to have you add some, usually it's contraindications that just haven't been input into the PMT. So you may see communication that says you have until the end of March, but that really takes away our opportunity to work with you. See that in green. Special note, once your director has confirmed your award eligibility, do not edit and adjust the PMT, and I should have said on 2018 data. You can do anything you want on 2019 discharges, but please don't go back in and fix things once your director has said things look good for your application. So try to finish up all 2018 discharges soon. And the sooner the better, and we'll work with you and make sure that you're eligible, and then you can just get moving on. We can get year-end reports. We can help you with year-end reports for your committees and so forth, and then you'll be set to work on 2019. Just a reminder that April 5th and 6th, that's a conference called QCORE, which is called the Quality of Care and Outcomes Research Conference. It's a small conference in Washington, D.C., but it is going to be the new venue for our heart failure recognition event where we'll be recognizing silver and gold level hospitals. It gets confusing because it's 2019, but that'll be for their performance in 2017. We're always kind of we're like the government, we're on delay. Just so you remember, May, the recognition awards based on 2018 data are approved and distributed. There's your Q1 data deadline and so on and so forth. The U.S. News and World Report ad where the gold and silver hospitals are recognized is usually in July. Questions related to dates or this award identification period, because we want to make sure everybody is able to get recognized for the hard work you've done. While you're thinking, just a reminder, don't forget AHA guidelines on the go. Get this on your phone. It's through the App Store. And whenever if you haven't been in there for a while, you need to go in and be sure and update, and it will bring any new guidelines in for you. All righty. Any questions, things you need addressed? We are glad to answer. And we've got 7-8 people who together can come up with the answer. On the line.
There is one question, yes, but unfortunately I could only see half of it. Has any other institution had struggles with? And that's where I'm cut off.
Oh, shoot. Whoever just answered, do you mind just doing *6 and giving us the rest of it? Because I'm sure the answer is yes. We just don't know what they're. I can see it. Q&A. That's so funny. Oh, here we go. Okay, I see some. Just a second. VAD population. I can't see the whole question either. We're having a little technical difficulty. I see Laura's question. Well, just whoever put that in, just do *6 and.
The rest is with their VAD population on discharge appointment.
Okay, so they've got a VAD. Okay. Anybody struggle with VAD, getting that in their discharge appointment? Well, I'll open that up to the group. Anybody who's been on who wants to just *6 and tell us how you've dealt with the post-discharge situation with VAD patients. And we can put out further inquiries. That's not one I've run into. If nobody has, I'll look into that a little further, and we'll put something in the follow-up email. All right. Well, I am here and available to answer questions, or otherwise I'm going to give you 13 minutes back to your morning. Just a reminder that the Quality Exchange for Stroke is going to be at noon today. We'll have a Quality Exchange tomorrow morning for resuscitation or Code Blue. Our noontime Quality Exchange tomorrow is atrial fibrillation, and Thursday morning at 8 a.m. Central, 7 Mountain, we'll have coronary artery disease. So this is the week for our quarterly Quality Exchanges, and if you want to, and you are welcome to attend any of the others, even if you don't have our modules. Other questions? *6. All right. Well, don't hesitate. If you want to hit, go ahead. Yes, hello.
This is Debbie from Wyoming. I'm kind of brand new at doing this stuff.
Oh, hi, Debbie.
Some of the times we have a hard time getting the appointments in 7 days because we're kind of a small community. Mm-hmm. And sometimes I get in with their PCP, sometimes I get in with a cardiologist. Does it matter which one it is?
No, it can be a physician, a PA, or an advanced practice nurse. Okay. But it has to be for the purpose of heart failure, not, just a general thing. It just needs to be for that purpose. So, yes, you can use other things.
The other thing I had to ask was, it looks to me like these questions are all related to patients with reduced ejection fraction. But whenever we get our list to put in, there's a lot of them that don't even meet that criteria.
So, in terms of with preserved ejection fraction.
Yeah, they have preserved ejection fraction. But
and we are asking you to continue to put those in. Certainly they still are to have the same follow-ups, but the guideline-directed therapies, if you remember, well, you might not know this because you're new, the evidence-based therapies for preserved ejection fraction, there are very few, if any. And so that is one of the reasons we're having those abstracted, because that's the newest area where we're working to make sure we have the evidence, and some of that could be in Get With the Guidelines, to have more guideline-directed therapies for the preserved ejection fraction folks.
So you still want that put in?
Yes, we do. And many of the things apply in terms of post-discharge, in terms of making sure some of the secondary prevention and the things that need to be measured on a regular basis, those still apply.
Okay, and I had said our doctor here, our medical director, cardiologist, feels like ARNIs are not something you should start in the hospital. He believes it's something you should start out of the hospital.
Because you have to have that washout period, especially if they've been on an ACE, that right. May very well be. And so that would be, it would be like it still won't fall out because you are able to answer that it's for later. So, but that's okay.
Well, they
That's
don't
why
ever
this
put that
is
in
not an achievement measure. It's not one of the 4 that we have to do. It's ACE, ARB, or ARNI.
Yeah.
So they just have to be on ACE, ARB, or ARNI. We're kind of watching that other ARNI piece separately, but the guideline still is ACE, ARB, or ARNI now. So
Okay,
it's going to continue to develop.
Do I have the most updated Get With the Guidelines abstraction tool? When was it last updated?
Let's see. That is a good question. When you go to your main page, and I don't know if I can do it while I'm showing slides, but when you go to your main page on the patient management tool, there is a little suitcase, and if you press that suitcase, it says coding instructions, and when you click that, those are the latest. And I can walk you through that, or Emily can walk you through that here after the call, because we do want to make sure you have the latest update.
The abstraction tool.
Well, the tool is always going to be updated because it's a web-based tool. So it's updated because you're using it it's an internet tool. So you're okay with the tool. What happens sometimes is you don't have the updated coding instructions. So we've changed how you're answering questions and you don't know it.
Okay.
So we'll make sure you have that. Which of the hospitals are you at up there?
Casper, Wyoming. Wyoming Medical
All right.
Center.
Yeah, we'll reach out and make sure you have the everything. But the tool will always be updated, sometimes to your chagrin because it'll get updated over the weekend and you're like, what happened? But, yeah, you always have the updated tool.
So now this post-discharge stuff is already updated.
It is not changed in the coding instructions, and that's why we're talking today, because they are changing the coding instructions. But unfortunately, they'll miss the award deadline. So we got an email from our committee and are allowed to work with you to make sure we get that corrected. And then there'll be formal coding instructions coming hopefully soon.
Okay.
And we can look through them with you, no problem.
Okay.
Cherie, this is Christy. I just want to let you know, I went ahead and logged in and looked for her, and the last time the coding instructions were updated was November 2018, so that's the most recent version.
Yeah. Thank you, Christy. Yeah, you'll want it. Yeah, I told you, we're a team. Want to make sure you're using coding instructions that are the November 18. And then there'll be another set probably, I'm guessing, March or April. So. And it's highlighted. The great thing about coding instructions, when you pull them up, anything that's highlighted means it's different than the last time you got them. Yes, someone asked a question?
Oh, hi, Cherie. My name is Nora from Houston Methodist.
Hi, Nora.
I just want to clarify. On the post-discharge appointment to meet that measure. It has to be within 7 days, I understand. So that was clarified by our team in the, no?
Well, let's remember, the post-discharge appointment, the question is, was an appointment put in the record before discharge or on the next business day? An appointment.
Yes. So we'll get patients that sometimes will get an appointment within 9 days. And so will that count as a post-discharge appointment? Because if I enter the date and I run the report, it will still show as a fallout on the post-discharge appointment if it's within 9 days.
It should not. You put yes. It should not. Mm-hmm. Why don't we look at that individually? Where's your hospital, Nora?
Houston Methodist.
Oh, Houston Methodist? Okay. Yeah, let's, we'll get on with Allison and look at that specifically because it should not. Is the appointment, and then when is the appointment? So it should not be a fallout. So it should be a fallout on the 7 days.
Yeah, that's what it should be. But since I was told that
you ran it and it's doing it.
No, I haven't been entering those with 9 day follow up. So then I should start doing that again.
You should. We'll reach out today and look at that specific to you, and so that I can report back to this whole group if that's not the case. But if you don't mind, we'll reach out and look through yours.
Okay.
Is that okay?
All right. Thank you. Thank you.
And you got your day-to-days report from Allison, right?
We do.
Okay. I just wanted to make sure she's got the right contact. So she does. Since that's her alma mater, I figured she has the right person. So, all right. Other questions?
Okay,
great.
thank you.
I'm so happy people are talking to me. Star 6. All right, we will send this out in writing. I'm going to meet with Nora and just make sure, we're it seems like she has a variation, and I want to make sure that's not the case. And please call your director or email your director today and say, I want to work with you on getting my post-discharge appointments fixed. And we will one by one work with you with your director and make sure we're optimizing what's there, getting the exclusions that are there, and if those appointments are there, getting you the recognition you deserve. So you can always email us, swaquality@heart.org, and ask questions, or just reply to your day-to-days email and talk to your own director, because we are here to give you a hand. So with that, any other typed in questions, Michelle?
We have one more.
Okay.
So sorry,
I don't have my screen proper. I can't see them all.
Sorry. For the patients who want to make their own appointment, how would we know that they did?
Well, that's like a patient refusal, and that is one of the options because they're doing it themselves. Now, it'd be nice if you ask them to report back to you or there was a way to do it, but I realize with hundreds of patients, that's probably not possible. Certainly, you should have a follow-up process where you're calling these patients back. You know, that's kind of a heart failure management system to see that they actually are doing what they need to do, but that's kind of a heart failure management part of this, not an achievement measure.
Okay, and Centura allows hospitalists to continue ARNI, but can't stop it. Only cardiologists can can't start it. Only cardiologists can start it.
Only cardiologists can start it. So they've made it as part of an exception in their formulary. So probably at Centura, hospitalists are the ones doing it, but they don't have the mechanism to actually do that. Well, that's interesting. That's kind of a change in the formulary process and in the hospital-specific process. So that's something you want to work through with your champion and seeing if they're wanting to change that based on us kind of being behind the nation in ARNI adoption, especially with those significant mortality adjustments. So I think we're just figuring it out right now based on cost and mechanisms, and do we have provisions in place for hyperkalemia.
And for 2018 data, can we call the patient's PCP to verify they had a follow-up appointment?
Yeah, and I think I answered Amy on that. That's fine. Yeah, I think if you've got the time to do that, that would be great. And maybe you can just send them a list, and they can give you the list of any of your patients that have seen. That is continuum of care, and so that is not outside the PHI sharing element.
Perfect, Cherie. I think that's all I have on my list.
Okay. Well, perfect timing. We've got 1 minute to go. Thank you so much for all the work you're doing with our heart failure patients. Please reply back to your director and let them know what help you need. We have 2 months here to work on your data, look back in, and we want to make that as efficient process as possible. Thank you so much, and don't forget to share with your colleagues that there are other quality exchanges. You should have a flyer that was on your day-to-days email that tells about all the other quality exchanges, and we're here to help you anytime. Thanks so much, and have a great day. Bye-bye.